the jugular venous pulse. The JVP stands for both the jugular venous pressure and jugular venous pulse. We can use it synonymously when we want to use, but most commonly it is used as a jugular venous pulse. Now, this is one finding which all of you should see in all of your cases, let it be valvular heart disease, congenital heart disease, ischemic heart disease, cardiomyopathy, or pericardial diseases. So what is the JVP, jugular venous pulse? So typically it is defined as the oscillating top of the distended proximal portion of internal jugular vein and represents the volumetric changes that faithfully reflect the changes in the right heart. So we all know that the JVP reflects the changes in the right heart, the right ventricle during the systole, or the right atria during the diastole, and it is directly connected to the internal jugular vein and the external jugular vein. We'll come to the point why internal jugular vein is used and not the external jugular vein, and why we see on the right side and not on the left side. So this is the definition. You may not remember, or you may not cram the definition, but you should know what it actually denotes. It is the oscillating top of the IJV. So what you see normally, it is not the A wave or V wave. You see the mean jugular venous pressure. You don't see the A wave height or V wave height. You see the mean height of the jugular venous pressure, and accordingly you can tell which wave is prominent, A wave or V wave, accordingly. So this is one important point which you should know. We do not see the height of the A wave or V wave. We see the mean jugular venous pulse in a JVP. So it denotes the right atrial pressure during the systole and the right ventricular filling pressure during the diastole. So it can be the right atrial pressure or the right ventricular pressure. You can see the image above. It is a jugular vein, and it's a balance between the central venous pressure, which is very important, and it is a window to the right heart, and it tells all the hemodynamics which is happening actually in the right heart. Now, McKenzie in 1902 told that in the study of the venous pulse, we often have direct means of observing the effects of systole and diastole of the right atrium and systole and diastole and the right ventricle. But this was what was told by the Paul Wood. Paul Wood is very famous because he has given too much to cardiology, let it be the Eisenmenger and various other things. So Paul Wood is a known person in cardiology. He has given a lot of contributions. So he told that the precise analysis of the cervical venous pulse and measurement of the height of each wave is not only possible at the bedside but highly desirable. So we should know that it not only shows that the hemodynamic, we can say many things with the JVP. So let us discuss one by one about this AA thing. Now we will discuss over the next 1 hour about the anatomy of the internal and external jugular vein, JVP measurement, how do you measure, and how, when clinically you have to tell about a JVP, what all points do you use to explain a JVP. What are the causes of elevated JVP, what is the normal waveform and what is the abnormal waveform, and there is something known as the Kussmaul sign, that is the respiratory variation, and hepatojugular reflux. When the JVP is not elevated or not seen, then what are the various measures you can do to make it prominent? That is known as a hepatojugular or abdominojugular reflux, and some other specific condition where you should see the JVP. Now, before coming to that, we know there are two important veins, that is the internal jugular vein and the external jugular vein. Now, why do we use only the internal jugular vein? Now, there are various points, but the most important point is the internal jugular vein is in direct continuity and in a straight line with the SVC. So that is the first and the foremost important point why we use IJV and not the EJV. It is in a straight continuity with the SVC and thus the right atrium. Second most important thing is it is either it doesn't have valves or it has very few valves compared to the external jugular vein where multiple valves are there, and so the pressure cannot be directly reflected. So IJV doesn't have valves compared to the EJV. And third important point is unless the EJV, because it is coming from the left innominate vein, it is compressed by the arch vessels or aortic aneurysms and between the arch vessels and the sternum. So the kinking is too much in the external jugular vein unless the IJV, which is in the straight proximity, so there is not much kinking. So these three reasons are the most important reason why we use a IJV and why we don't use a EJV. Now this is one of the important anatomy. You know there is a triangle, the sternocleidomastoid, the base is formed by the SVC, and then we have the sternocleidomastoid muscle. The IJV is deep to the sternocleidomastoid muscle. It is lateral to the common carotid artery. The carotid artery is medial. Internal jugular vein is lateral. EJV is more superficial. IJV is deep to sternocleidomastoid muscle. So this is one important anatomy which you should know before seeing which part do we see the JVP. Now, as I already told, it is lateral to the carotid artery and deep to the sternocleidomastoid muscle. External jugular is superficial to the sternomastoid. Now, this is what I told you. You can see the triangle, the path of IJV. It is just between. It is the where you. I think most of you will be taking the punctures of IJV, so you will know where you see a jugular venous pulse. You know the external jugular vein is more superficial, more lateral. The IJV is lateral to the common carotid artery. It is in the triangle formed by the sternocleidomastoid muscle and the clavicular head. And the clavicle forms the base of the triangle. Now, JVP examination, as I already told you, there are various things which you have to tell in a JVP. Like when you explain a JVP, you should tell JVP is pulsatile or not. Why it is important? Because one of the important cause of non-pulsatile JVP is SVC obstruction. There are many causes of the pulsatile JVP. However, non-pulsatile is seen in SVC obstruction. Then you should tell the JVP is raised or not. I'll come to the point. How do you say the JVP is raised or not? Then you should say which waves are prominent. There are ascents in JVP, which are the A wave, C wave, V wave. C wave is usually not seen in JVP, but there are various descents like X descent, Y descent, which are the important. And then you have to see if the JVP is not raised, you have to do whether you have a positive hepatojugular reflux or not, and what is the variation with respiration. Whether on inspiration, normally there is a fall in JVP, and if it is paradoxical, that is a paradoxical rise of JVP with inspiration, it is known as Kussmaul sign. We'll come to it one by one. Now, why right IJV is preferred? I already told you it is in a straight line and it is less likely to be compressed by the arch vessels, aneurysm, and between the sternum. And why not EJV is there are less valves or no valves in the IJV as compared to the EJV. Now, this is one important question which they will always ask you in JVP is what is the difference between whether it is a carotid pulse or whether it is the IJV. There are 6 to 7 points which is not, you should not just remember, you should know it practically. The JVP is usually a superficial structure and it is a laterally in the neck. As I already told, carotid pulsations are deep and they are medial. JVP is better seen than felt. As we already know, carotid pulsations are better felt than seen. JVP always has two peaks. Two peaks are A wave and V wave. Two troughs are X descent and Y descent. Whereas a carotid has only one single upstroke. The descents are more obvious than the crescent. I will get again to it. There are X and Y descent which are actually more obvious than the A and V waves, and X descent is the one which increases more with inspiration, as compared to carotid which has an upstroke which is brisker and more visible. Now we already know that digital compression abolishes the venous pulse. However, digital compression has no effect on a carotid artery pulsations. Inspiration and abdominal compression has effect on JVP but not on the carotid pulsation. So these are the points which you should know to distinguish a JVP from a carotid artery pulsations. Now, how do you measure? Now, when measuring it, there are various measures. You should measure the jugular venous pressure. You should always see the hepatojugular reflux and examining the veins on the dorsum of the hand. I will come to it because there is something known as the Gartner method, where in a sitting position, if the JVP is too much raised, you may tell that the JVP is not raised, but you will miss the very high JVP. Why? The neck veins will be very much engorged, which is an indirect sign that JVP is raised. And then your hand visible pulsation, there will be veins on the dorsum of the hands which are very much dilated, which is the indirect indicator that the JVP is raised. So what okay, I'll come to it again about the Gartner's method, and also you have to see the JVP at the bedside very carefully. Now, as you already know, I don't want to explain in detail, but it is one important point. What is the reference point? It is the angle of Louis. You should not pronounce it as Louis because IS is silent. It is the angle of Louis which is taken as the reference point, and you know the angle of Louis, which is the sternoclavicular point, which is one important point, and at the second rib, Now, why there are various methods because of which this was taken as the reference point, and we already know that the right atrium is 5 centimeter above this point, so below this point. So when you take a JVP, you should always remember that 5 centimeter you have to always add, because this point is 5 centimeter from the right atrium, and the sternal angle and the right atrium has always a fixed relationship. This 5 centimeter will never change. Now, one thing which I want to change is not much, may not be important, but some examiners may ask you, can you use the JVP from the clavicle? If you see the Brownwell book of cardiovascular medicine, the current reference point is the clavicular head and not the sternal angle. However, we should always tell that the JVP is raised this much above the clavicular head and this much above the sternal angle. The 5 centimeter is constant, that you have to add 5 centimeter in both the ways, but from the clavicle also it is 5 centimeter and from the sternal angle. But if they ask you, do you use clavicular head, that it is the reference point at present, and the sternal angle also is used. So you should always remember the clavicular head also as the reference point. Now, how do you measure? Now, many people ask me, why do we see the JVP in 45 degree and why not in lying down position and always in sitting position? See, at present, the ideal position to see JVP is the sitting position and not the 45 degree. You should always see in JVP in the sitting position. Now, why do we used to see JVP in 45 degree? Because when you lie down supine, the JVP is intracranial, and when you sit fully, the JVP is intrathoracic. That is why the 45 degree is a place where you can see the JVP correctly. Now, how do you see it is? You should ask the patient to lie down comfortably, elevate the chin and slightly rotate the head. You should not make much tension on the head. Some degree, 30 degrees enough, and neck and trunk should be in the same line. When the neck muscles are relaxed, you should always try to use a light. Shine the light tangentially across the skin. You should not put it from the anterior or not put it from the posterior. You should put it tangentially and see the pulsations. And one important thing is, you should always palpate the left carotid artery, because you cannot tell which waves are prominent unless you tell the carotid arteries timing. Because there are, I think you will be knowing, what comes with the carotid is the V wave and what comes off the carotid is A wave. The A wave is before the S1, just before the S1, and V wave follows the S1. But you should not confuse this. You should remember what comes with the carotid is a V wave, what comes off the carotid is a A wave. So this thing is one important clinical finding which you should know. Most of the time we usually do it with the carotid. Some people do it with the apical impulse. In that, the apical impulse corresponds to the S1, and what comes before S1 is a A wave, what comes after S1 is a V wave. But I think you should always try to do it with the carotid, which will be very perfect. Now, this is the thing which I told you. Take two scales. It is the most important. It is the vertical scale which is more important than the horizontal scale, and do not take the horizontal distance. It is the point at which the horizontal scale cuts the vertical scale is the height of JVP. So that is more important. Now, suppose in a 45 degree you are seeing a JVP pulsation and it is 6 centimeter above that sternum. That is the height on the vertical scale is 6 centimeter where it is cutting the horizontal. So you should add 6 plus 5, that is 11 centimeter. Now, even if you tell 11 centimeter, it is fair enough. But many a times, because anything which is more than 8 mmHg. So how do you convert into mmHg? Is 11 divided by 1.36, because we know that it comes from the 760 or 1.36 mmHg. So if you divide it by 1.36, you will get in mmHg. So any JVP which is raised 7 to 8 millimeter of mercury, it is raised. So this is one thing which is you should always remember. Any JVP which is raised 7 to 8 millimeter of Hg, it is raised. So this JVP will be raised. Now, there are, as I already told, there are two scales you should use. If you are telling it up more than mmHg, you should use 7 mmHg or more is raised JVP. If you are using centimeter of water, any JVP which is more than 4 centimeter above the sternal angle, it is raised. So these 2 points you should raise, but don't confuse. Always try to remember one of these things. And I always tell you should see the JVP in sitting position, because any JVP which is raised in sitting position, it is raised. There are some waves which are prominent at the fossa, in supraclavicular fossa, which may be normal, but above that, any waves which are seen, it is a raised JVP. You should always remember. Now this is what I told you, how to calculate the JVP. It is an important point. Now before going to the next heading, we should always know the causes of elevated JVP. I am not talking about the waves. What are the causes of elevated JVP? See, all the things where any wave is prominent is the causes of raised JVP. But overall, you should know that right heart failure, any cases where right heart failure is there or incipient right heart failure is there, are the causes of raised JVP. But even in the patients who have a volume overload, you can find a raised JVP. Patients with anemia, volume overload, CKD, these patients have high JVP. So these are the causes of raised JVP. Now, so as I already told you, apart from the cardiac causes, ascites, as you already know, cirrhosis of liver, high volume, because these are high volume states and they reflect the LV pressure. So high volume states in LV pressure, means the patient, they have a high LV EDP, can even reflect your. Am I audible?
Yes, audible.
Yeah. So apart from the cardiac causes, the conditions such as CKD, ascites with cirrhosis of liver, and excessive fluid administration if you give to a patient, these are the causes of raised JVP. As I already told you, non-pulsatile JVP is seen in SVC obstruction. I will tell you one practical point. Before seeing a patient's JVP, make a habit of seeing both the right side and the left side. Never see only the right side of the neck. Always see the left side of the neck, because there is a condition known as LSVC, that is the left superior vena cava, where the JVP is seen on the left side. So if there are many cases where many people pick up a LSVC, which is the echocardiographic finding, by seeing the JVP on the left side. So always see the venous pulsation also on the left side apart from the right side. Now, before going to the further thing, I would like to add what is Kussmaul's sign. So I already discussed with you. Normally, what happens with the raised inspiration? On inspiration, there is normally a fall in there is an intrathoracic pressure rise, and the intrathoracic pressure rise causes a JVP, increase right atrial. The right atrial, the blood will go to the right atrial filling and it will go to the right ventricle. However, if there is a paradoxical rise in JVP, now what is happening in the patients with RVMI or the patients with restrictive cardiomyopathy, constrictive pericarditis, these are the cases, or a RVMI, or those are the conditions where, because the RV is thick, the RV cannot take much blood. So the RA pressure increases and the RV cannot take much blood. So the whatever the blood is coming is not able to go to the RA and RV. So paradoxically, it goes back to the SVC. I think you understood it. So if the on inspiration, because in cases of CCP, because the pericardium is thick, in RVMI, because the RV is dysfunctional, or other cases of RV dysfunction, and restrictive cardiomyopathy, because there is a restriction in the filling of the RV, these are the case where the RV cannot take the blood. So instead of the RV, the blood goes from RA into the SVC, and so the JVP increases. So the paradoxical rise in JVP with inspiration is known as the Kussmaul's sign. So as I already discussed the condition, constrictive pericarditis, RV dysfunction, right heart failure, RVMI, restrictive cardiomyopathy, these are the causes of Kussmaul's sign. And you should see in all the cases with RV dysfunction or what are cause, I told you whether a Kussmaul's sign is there or not, because you may hardly be able to pick many Kussmaul's signs, but if you are able to see and pick it up, it is a very good thing. Now, one important thing is abdominojugular reflux or hepatojugular reflux. Now, why we have it's important is, many a time if you don't see a prominent JVP, you will tell in the exam JVP is not raised. Without doing a hepatojugular or abdominojugular, never commit to this finding. Always do a hepatojugular reflux. And why do we tell it abdominojugular is, many patients who have RV dysfunction have a tender liver. They have tender hepatomegaly, and if you compress the liver, it is a bad sign. You should not do it. So they have come up with a newer thing is, do a abdominojugular. You can compress over the umbilical area instead of a hepatic area. So you should always remember to do it in a sitting position and not in a lying down position. Patients should be very quiet, and you should prior explain to the patient what you are going to do, because suddenly if you do it, patient may do a Valsalva and it may reflect a wrong finding. Also, you should not make sure that the patient is not doing a Valsalva. You should not make him do a Valsalva, and patient should be quiet, neither inspiring or not expiring. He should be quiet. Now what you have to do is apply firm pressure to the periumbilical area for 30 seconds. 60 seconds will be too much. Apply for 30 seconds. Normally what happens is there is a rise in normally JVP rises transiently to less than 1 centimeter while the abdominal pressure is continued. Now when you are giving the pressure for 30 seconds, the JVP will rise transiently and then it will come back. But when you release the pressure, it should not be there. This 1 centimeter rise should not be there. Now when do you say that hepatojugular reflux is positive? Now you have compressed the abdomen and you have left it. Even on leaving the compression, if the JVP is raised more than 3 centimeter, sorry for that mistake, it's more than 3 centimeter, which should be raised for more than 10 to 15 seconds, means at least 10 cardiac cycle. So if the JVP is raised more than 3 centimeter for more than 10 to 15 seconds, it means there is a positive abdominojugular reflex. It means there is an incipient or early right heart failure, which we are not able to see in a prominent JVP, but we have done a hepatojugular reflux. Now, as I already told you, a failing and dilated RV may not be able to receive the venous return without a rise in mean venous pressure, and that is the cause of a prominent hepatojugular reflux. Now, the causes are positive abdominojugular reflex, as I already told you, is seen in a compensated, not a decompensated, but a compensated right heart failure or an incipient right heart failure. Also in the cases who have a TR, but not a prominent V waves or a prominent A waves on JVP. If you do a hepatojugular, you may see the JVP become prominent or the V waves become prominent. One of the important causes COPD. It's COPD patients they may have some degree of cor pulmonale and they may have a positive abdominojugular reflux. So this is what I told you. Inspiratory, on compressing this, you are able to see this, and on releasing, you are able to, it becomes normal. Now coming to I also wanted to tell you one thing. In the patient who have Budd-Chiari syndrome or the compression of IVC or the compression of SVC, you may not be, are the causes of false negative hepatojugular, because the Budd-Chiari is obstructed, so no intra-abdominal, if the pressures or IVC is obstructed, they are not able to transmit to the thoracic. So anything where SVC obstruction is there, Budd-Chiari is there, or IVC obstruction, they are the causes of false negative abdominojugular reflux. There are few causes of false positive abdominojugular reflux. One important thing is high volume overload. So if the patient has volume overload state, it may also have a positive hepatojugular reflux. That is a false positive hepatojugular reflux. So this thing is, you should always remember. Now coming to a normal JVP. Now as I already told you, it reflects the phasic changes in the RA during the systole and the RV during the diastole. There are two positive, actually there are three waves, but because the C wave is not appreciated, there are two positive waves. Positive waves means it comes outward. You can see a pulsation which are outward, and the negative are troughs, that is X and Y descent. Why they are called descent? Because they are negative, they go inward. So positive waves are A and V, and the negative waves are X and Y descent. Apart from this, there are additional waves which I already told you is C wave. C wave is when the bulging of the tricuspid valve into the right atrium during the isovolumic relaxation time. So when there is a bulging of the tricuspid valve into the right atrium during the IVRT, it is the cause of C wave. And we also have some waves known as the X dash wave and H wave. Now let's come to it one by one. So the three waves which are from positive waves are A, C and V, and three descents, that is X descent, X dash. Even if you don't remember X prime, it is okay because it is not much important. But X and Y descents are very important. As compared to the cardiac cycle, where does A come is, A is a pre-systolic. So A is a diastolic event. X, then we get a X descent. So why do we get A is A is due to pre-systolic, that is atrial contraction. Because of the atrial contraction during the diastole, the blood goes to the SVC, and so the blood is reflected in the JVP. After A wave, you get a atrial relaxation, that is the X descent. And after the X descent, when the tricuspid valve is closed, there is a bulging during the isovolumetric relaxation time. That is, all the valves are closed, but the volume is constant, but the pressure is rising. So because the pressure is rising, the tricuspid valve is bulging into the right atrium. That causes a C wave. So there are two hypotheses of C wave. One is the bulging of the tricuspid valve into the right atrium, and second, they say it is due to the carotid artery pulsations. We see a C wave. Not much important, not seen in JVP. You may just neglect it, but know the mechanism. After C wave, you get something known as the X dash. So X dash is due to the two things. One is the RA is now the tricuspid valve opens, and second is the floor of the RA. The floor of the RA comes down. So these are the two important causes of X prime. After that, you get most important, one of the important wave is V wave. Now V wave, what happens now? There is a filling of the RA. So RA gets filled from the SVC and from the IVC, and that is why you get a V wave. Starts in the late systole and continues into the early diastole. So a V wave can be told as both a systolic and a diastolic, because it is both in the late systole and the early diastole, and it is due to the filling of the RA from the SVC and the IVC when the tricuspid valve is closed. That is why in TR, because the tricuspid regurgitation is there, you get a prominent V wave, because not only the blood is coming from the SVC and IVC, it is also coming from the RV into the RA. Following the V wave, when the tricuspid valve opens, you get a prominent Y descent, because all the blood from the RA is now coming to the RV, and that is why it is a diastolic Y descent, which is a diastolic event. It's also called a diastolic collapse. So all the blood from the RA comes to the RV. Now after a Y descent, there is some wave which is known as the diastosis. So we know that the early filling, it is also in the cardiac cycle, you would have heard, that is a diastasis. So the early filling of it's what produces the Y wave, and that is why in the constrictive pericarditis, where the early filling is not affected, you get a prominent Y descent. And in cardiac tamponade, where even early filling is hampered, you get an absent Y descent. Now after a Y, you get something known as a diastasis wave, which is in the mid diastole. So the filling of the RV during the mid diastole produces a H wave. The H wave is you may not be able to see in a neck veins, but it is usually appreciated when the patient has more bradycardia during a slower heart rate as compared to the tachycardia. So these are the various waves which you should know. Before starting, I just want to halt and ask if there is any doubt, because I am maybe going very little faster. Okay.
Yeah, if any student has any doubt, can ask. And
because this is a bigger topic, very big topic, so I want to go slow.
I will like to add one line in hepatojugular reflux. First thing in exam, we should not tell it's a reflex, it's a reflux. And second very important point, like what Harrison has given now, like it was hepatojugular and then becomes abdominojugular, because putting the pressure on abdomen, as there will be the liver tenderness. Now what they say is, even if you elevate the limb for 15 to 30 seconds, that is also fine to do hepatojugular reflux. So that also serves the purpose of putting more and more fluid to the RV, and RV won't be able to take it, and then it gets up. So that Harrison has added now that we can do even abdominal jugular reflux just by elevating the limb.
Yeah, it is hepatojugular reflux. Always remember, don't tell reflex.
Yeah, that happens. Many people tell reflex. Okay, but at this point, we should tell it reflux. Examiner get offended. Otherwise it doesn't matter. Okay, if no doubts or something, or even if you have doubts, you can put me on a WhatsApp also, so I can answer. I can ask her directly. Yeah. So I think we'll go ahead. Yeah. So
let's come to the first important wave. As I already told you, A wave. A wave is a first positive wave. So it's a pre-systolic wave. That is, it's a diastolic wave. It is due to right atrial contraction. Now, what happens when the right atria contracts? It contracts against a closed tricuspid valve. Now, what is happening is When the right atrial contracts against a closed tricuspid valve, all the pulse effective blood, it is goes through the SVC, and that is why you see a diastolic A wave. So it is the effective RA contraction which is important. Also, it's a dominant wave in JVP and always larger than V wave. You should just excuse me. Yeah, you should always remember that in a right atrium, it is the A wave which is more larger than the V wave. However, on the left atrium, it is the V wave which is more prominent than the A wave. So this point you should always know. And it precedes the upstroke of carotid, that is, and S1. That is what I told you. It is atrial contraction, so it precedes S1. It's before S1, but it follows the P wave on ECG. And you should always time with the carotid. If it is coming with the carotid, it is not the A wave, it is the V wave, and it is coming off the carotid, it is the A wave. So this point you should always remember the timing with the cardiac cycle. Just without seeing the apical impulse or without touching the cardiac other side carotid, don't tell that it's a wave or a V wave. There are various differences between a wave and a V wave. Like a wave is a flicker wave, whereas a V wave is full undulant. It is a dancing wave. You cannot miss a wave with a V wave, because A wave is a firm, it is at one point, it's just a flicker, whereas a V wave is like an undulant wave. It's a full skin neck which pulsates, a part of the skin which pulsates. That is a V wave. So it is very difficult to difficult to pick it up, a V wave. Also, a V wave comes with the carotid, A wave comes off the carotid. So these two things are very important. Now going to the X descent. Now what is the X descent? As I already told you, because of atrial relaxation. So it is a systolic X descent. It is due to the atrial relaxation during the atrial diastole. It is a systolic X descent, but it is during the atrial diastole, but it is a ventricular systole that time. So X descent is more prominent motion of the normal JVP, and it stops just before the S2. Always remember the X descent is the most prominent descent, and sometimes it is more prominent than the A and V wave. And it is one of the most important wave which increases the most on inspiration. So on inspiration, X descent becomes more prominent. Though the JVP decreases on inspiration, the mean arterial venous pressure or mean pressure, it always increases. This you should always remember, and it is always larger than the Y descent. Now C wave, as I already discussed, it's not usually visible. There are two mechanisms. One is the upward bulging of closed tricuspid valve during isovolumetric relaxation time, and transmitted carotid artery pulsations. Normally we do not tell C wave, but sometimes in a severe tricuspid regurgitation, we tell CV waves. Now in this diagram you can see there is a C wave and there is a V wave. Now what happens in tricuspid regurgitation is the X descent. The absence of X descent is an earliest feature of a tricuspid regurgitation. You may not be able to appreciate on a JVP, but the absence of X descent is one of the earliest finding of tricuspid regurgitation. So if in the image you remove the X descent, it becomes a CV wave. That is why we always tell a CV wave is prominent in severe tricuspid regurgitation, and a Y descent becomes more prominent. That is the Friedrich sign, what we call it, in a tricuspid regurgitation. So these 2 points you should always remember with tricuspid regurgitation. This would have been explained to you. There are various other findings of a tricuspid regurgitation on examination, like a patient has a bobbing pulsation of the eye. There are exophthalmos may be there. Neck, ear pulsation. So if a patient has prominent ear pulsation, it is one of the features of tricuspid regurgitation. Also, you can see the exophthalmos, you can see the pulsatile lever. A pulsatile lever or a systolic pulsation is seen in tricuspid regurgitation, and ascites may be there. So these are the other points which is important in tricuspid regurgitation. Excuse me just for a second.
So meanwhile, if people have any doubt or anything regarding speed, or if you are finding it's fast or slow or something, you can message me. I can convey to him. Yeah.
Okay. Sorry, Sanket.
No, continue.
The C wave. Yeah. we get something known as the X prime or the X descent. So it is a systolic trough after the C wave. And as I already told you, there are two mechanisms. X prime is due to the fall of the right atrial pressure, and the RA blood comes to the RV during the early systole, and also the floor of the RA comes down. So like in atrial fibrillation, which is one of the not only one of the important causes of absent X descent, their X prime is sometimes preserved in atrial fibrillation. So many a time they will ask you what happens to the X prime. So in atrial fibrillation, you get absent A wave, you get absent X descent, but the X prime may be preserved. So this is one of the important findings. Now it is also due to the downward pulling of the tricuspid valve by the contracting RV. So the RA floor comes down, and the descent of the RA floor. So this point you should just remember, may be important theoretically, not much practically, but you should just remember. Now V waves, as I already told you, it begins in the late systole, it ends in the early diastole. So actually, ideally, historically it is a systolic wave, but it goes into the diastole. Now what happens is, as I already told you, rise in RA pressure due to continued RA filling during the ventricular systole. Normally the V wave happens during when the tricuspid valve is closed and the RA continues to fill from the SVC and the IVC. So it happens with the carotid. So it comes with the carotid, as I will again and again tell you, do not miss. It comes with the carotid, A comes off the carotid. It corresponds to the S2. It comes after the S1, A wave comes before the S1. It comes with the S2. It corresponds with the S2, the V wave. And then comes the Y descent. It is also called a diastolic collapse wave. Why? Because the RA opens and all blood from the RA in the early diastole comes to the RV. It begins and ends during the diastole well after the S2. And the decline of RA pressure due to RA emptying during the early diastole when the tricuspid valve opens. That is why in tricuspid regurgitation it becomes a prominent, because all the blood which is in the RA has to come to the RV, and that is why you get a prominent Y descent in tricuspid regurgitation. Now just a small point on the H wave, which I have already discussed, is a small brief positive wave following Y descent. It is called H wave because it was given by Hirschfelder, and it is usually seen when the diastole is long, like in cases of bradycardia. So it is due to a mid diastole, that is a diastasis phase, it is seen. Now let's come to the causes of prominent. That is what you are asked in the exam. Till now what I am told is much theoretical, but let's come to the So as I already told you, A wave is due to the atrial contraction. It is a diastolic wave. When during the diastole, atria contracts, all the blood goes to the SVC, and you get a prominent A wave. So what happens is, you can either get it due to the obstruction to the inflow, because RV inflow obstruction, or the RV compliance has decreased, that there is too much right ventricular hypertrophy, you can get a wave. So due to the RV obstruction, what are the causes? Most common tricuspid stenosis and the atria myxoma, right atrial myxoma. Tricuspid atresia is a rare cause. You can just remember stenosis and RA myxoma. And when does the RV compliance comes down? Most common cause is PH. If somebody asks you what is the most common cause of a prominent A wave, it is pulmonary artery hypertension, because of which RV hypertrophy, RV compliance comes down. RA has to contract against a tight RV or a very low compliant RV, and that is why. Apart from pulmonary hypertension, another important cause is pulmonary stenosis. Because of pulmonary stenosis, the RV becomes hypertrophy and the compliance goes down. In cases with RV infarction, also the RV compliance goes down and you may get a prominent A wave. One important cause is hypertrophic cardiomyopathy and aortic stenosis. Many people will ask you, in case of aortic stenosis, which wave is prominent? It is a prominent A wave. What happens is, because of the AS and hypertrophic cardiomyopathy, there is a severe left ventricular hypertrophy which shifts the interventricular septum on the right side. That is also called as Burnham phenomenon. That is the opposite of reverse Burnham. It is a Burnham where the LVH causes a shift of septum towards the RV, and the RV compliance comes down. So aortic stenosis and hypertrophic cardiomyopathy are important causes of prominent A wave, and the mechanism I have already told. Apart from that, one of the rarer causes which we do not see in JVP much is acute pulmonary embolism, where the RV compliance comes down and we get a prominent A wave. So if you remember this much causes and this much mechanism, I think it is fair and well in the exam. Now, as I already told you, you can see a prominent A wave which comes off the carotid, which comes after the P wave, which comes before the S1. As I told you, everything you can see in this before the S1 with the carotid and after the P wave on ECG. Now there is something known as the Cannon wave. Now every time people will be asking you what are Cannon waves. Cannon waves are nothing but a giant A waves, and it is due to the contraction of atria against a closed tricuspid valve during RV systole. When the atria contracts against a closed tricuspid valve, it produces a Cannon A wave. Now what is the difference between Cannon A wave and normal A wave? Many people will ask you. But the typical answer is Cannon A waves are systolic waves and typical A waves are diastolic waves. So this difference you should always remember. Cannon A waves are systolic event and normal A waves are diastolic event. So what are the causes of Cannon A waves? You should ideally divide it into regular and irregular, because if you see a JVP, you can, if a Cannon A wave, I think in all the cases of ventricular tachycardia, if next time you see a patient, just see the JVP. In all the cases of complete heart block, if you see a ECG, always see a JVP, and I am sure that you will never miss a Cannon A waves. So if it is a regular, you should divide it into bradycardia and tachycardia. If it is irregular, you divide it into bradycardia, tachycardia. So a regular Cannon wave with a bradycardia is a junctional rhythm. A regular Cannon wave with a bradycardia is due to a junctional rhythm, and a regular Cannon wave with a tachycardia is due to ventricular tachycardia without AV dissociation or with a AV association. So if you do not have a VT with a AV dissociation, if what is AV dissociation? You get more V waves compared with a P waves. So that is what is known as a AV dissociation. So if there is 1-to-1 conduction in a VT, you get a regular tachy Cannon wave. However, if you get a ventricular tachycardia with AV dissociation, as you already know, AV dissociation is a typical finding in ECG. If you get that, it is VT. If you do not get that, it doesn't mean it's not a VT. It can still be VT, but if you get that, it is a VT on a ECG. So irregular Cannon waves with tachycardia is ventricular tachycardia with AV dissociation. However, irregular Cannon A waves with bradycardia is complete heart block. So these four causes you should just remember: regular brady junctional rhythm, regular tachy, ventricular tachycardia with VA association. Irregular Cannon with tachy is ventricular tachycardia with AV dissociation. Irregular Cannon wave with bradycardia is complete heart block. Other cause you can just forget for the time being. Now this is what I told you are the regular Cannon A waves. See, as I already told you, the last slide which showed was a diastolic event. Now this is a Cannon wave which is a systolic event. Now coming to the absent A wave, there are many causes of a prominent A wave. There are not much causes of a absent A wave. So in patient with atrial fibrillation, A wave is absent. Also in patient with a hyperkalemia, it is one of the important things. You can see a patient with hyperkalemia, they have a atrial paralysis and then they have a absent A wave. One important causes, I think, is if somebody asks you maybe for your gold medal, is sinus tachycardia. In patient with sinus tachycardia, A and V wave merges and you do not get a wave. So that is one of the important causes of an absent A wave. Now in many cases with mitral stenosis, you have a raised JVP, but always see the pulse. If you are getting irregular pulse, do not tell that A wave is prominent. That is what that MS with atrial fibrillation with raised JVP. If you get the whatever wave is prominent positive is a V wave, and then you can definitely tell there is a severe tricuspid regurgitation and pulmonary artery hypertension, because the atrial fibrillation is there and definite you cannot get a wave. So this is one of the important bedside tricks which I want to tell you. Now apart from the absent A wave in atrial fibrillation, you also get an absent X descent and you get a X prime which is usually preserved. Now what is the causes of prominent X descent? So after A wave, there is something known as a X descent. So there are two important causes of a prominent X descent. Both the constrictive pericardial disease, that is a constrictive pericarditis and cardiac tamponade. Now why both of these causes prominent X descent is the presence of atrial relaxation with intact tricuspid valve and the good RV in the constrictive constrictive pericarditis, both the early diastole and the later part of the diastole is preserved. So you get a prominent X descent and you get a prominent Y descent. However, in the in a case of constrictive pericarditis, only the early part of the diastole is preserved. The later part of the diastole is affected. In a patient with cardiac tamponade, both the earlier part of the systole and the earlier part of the diastole and later part of the diastole is badly affected. That is why you get a Y descent which is absent, because the diastole is affected, which happens in early diastole. So the Y descent is absent. Now X descent is usually a systolic event. So in both the physiology, that is a constrictive pericarditis and the cardiac tamponade, the systolic events are not much affected, and you get a X descent which is prominent in both the constrictive pericarditis and cardiac tamponade. Again, I want to repeat for people who did not understand this. In both these physiologies, pericardial diseases, constrictive and pericarditis tamponade, the inflow, that is a systolic part is not much affected. It is the diastolic, the filling part of the RV which is affected. Now in constrictive pericarditis, the earlier part of the systole is not affected. It is the later part of the systole only which is affected. That is why you get both a prominent X descent and Y descent. In cardiac tamponade, the earlier part of the diastole is also affected, and that is why you get an absent Y descent which is seen in earlier diastole. The Y descent is seen in earlier diastole. So Y descent is absent in cardiac tamponade. There is one more. Apart from this, I already told you one of the important earliest sign of tricuspid regurgitation is an absent X descent. So X descent is usually absent in a tricuspid regurgitation. You should always remember, apart from atrial fibrillation, the earliest sign of a tricuspid regurgitation is an absent X descent. Now coming to the prominent X descent, as I already discussed, is cardiac tamponade and Now V wave. Let's come to the V wave, which is an important wave. Now, see, when anybody would have asked you V wave, only answer which will come from your mouth is a tricuspid regurgitation. Actually, it's correct. One of the important marker of a severe tricuspid regurgitation is a prominent V wave. You will be asked in the examination why you said severe TR, because prominent V waves are there, which is, apart from the prominent V waves, you also have a hepatic pulsations or a pre-systolic pulsations. You have ascites, you have a pedal edema. So all this says that the TR is severe. No, so severe TR is one of the important cause of a giant V wave, and as I already discussed, you will get the systolic movement of the earlobe, head bobbing movement, systolic pulsation of the liver, and pulsatile exophthalmos. These are the head-to-toe examination in cases of TR with a prominent V wave which you have to do. So as I already told you, in cases of a TR, because the X descent is absent, you get a fusion of a C wave and a V wave, which is known as the CV wave, with a very fast Y descent. So TR, one of the apart from absence of X descent, the Y descent is very steep, very fast, and it is known as a Friedrich sign. A prominent Y descent, steep Y descent, is known as a Friedrich sign, which is seen in a tricuspid regurgitation. So apart from a tricuspid regurgitation, there are two other important causes of a prominent V wave, maybe for a gold medal, is ASD with MR. So if a MR patient has a ASD, you know that the left-sided pressure is increased, so V wave are prominent of a left side. So via the ASD, it is reflected into the JVP. That is why you get a prominent V wave in ASD with MR. Also, Gerbaud's defect, where there is a LV to VSD, from the LV to the RA, a VSD from LV to RA, all the LV pressure, the V waves are reflected into the RA. So Gerbaud's defect is one of the important causes of a prominent V wave. So these three causes, if you know, I think it's done. Tricuspid regurgitation, ASD with MR, and VSD from LV to the RA, which is known as a Gerbaud's defect. Now coming to the rapid Y descent, I already discussed severe tricuspid regurgitation, also known as Friedrich sign, which is also seen as constrictive pericarditis, where the systole is not affected and you get a prominent early rapid ventricular filling. That is a constrictive pericarditis. So the earlier part of the diastole is not affected in constrictive pericarditis, whereas it is affected in tamponade. So you get an earlier rapid ventricular filling known as a Y descent. Also ASD with MR, like the V wave, it also causes a prominent Y descent. Two causes you can know is severe TR and constrictive pericarditis. Of rapid Y descent, it is more than enough. This is what I told you, Friedrich sign. You can see a Y descent which is very brisk. It is known as a Friedrich sign. Now slow Y descent. So anything which causes obstruction to the filling of RV, like a tricuspid stenosis and a tumors and a cardiac tamponade. So the cardiac tamponade, as I already discussed, again and again I am discussing, the Y descent may be slow or it will be absent. Tricuspid stenosis because the RV cannot fill, tumors because the RV cannot fill. So these are the causes of an absent or a slow Y descent. Now coming to the respiratory influences, as I already told you, Kussmaul's sign is the inspiratory rise of the JVP. Normally, though the JVP waves decrease with the inspiration, the mean venous pressure falls. The waveforms are usually accentuated. Though the mean venous pressure falls during the inspiration, the waveforms become prominent, and it is the A wave or X descent which becomes more prominent on inspiration. The wave becomes more prominent, X becomes very brisk, because increased venous pressure augment RA contraction and hence relaxation. So it causes a brisk X descent. And also the increased venous return augment the RV volume and contraction and causes the increased systolic descent of the floor of RA, which causes a brisk X prime. Now in arrhythmias, I won't go into in much detail because I have already told you before. Arrhythmias are one subset where you have to know the JVP. I told you free arrhythmia like the complete heart block, the ventricular tachycardia with VA dissociation, VA association, where the JVP is important. So I won't go into all the waves, but you should know that in presence of VT, you get a regular and a irregular. VT with AV dissociation, you get irregular and tachycardia. In VT with AV association, with you get irregular and a tachycardia. In patients with ventricular premature complexes, also Canon AV waves may be prominent. In patients of complete heart block, the Canon AV waves are present, they are irregular and they are bradycardia. All other cases like a first degree heart block, Venki back or a Mobitz type 2, the Canon waves are absent, but you have to see how you get the relationship between A and the V wave. Now, what happens in cardiac tamponade? They will ask you in exam, the JVP is elevated and then X wave is prominent, the Y descent is obliterated and the Kussmaul's sign is usually absent. It is the constrictive pericarditis where the typical Kussmaul's sign is positive. 80% of the tamponade, the Kussmaul's sign is absent. Only in 20% it may be present. But the typical find of a cardiac tamponade is pulsus paradoxus. You should always look for a pulsus. Maybe in tomorrow's class on pulse, I will tell you again, the pulsus paradoxus is very important because on inspiration, what happens with the BP, the BP falls less than 10. But if the blood pressure falls more than 10 mm of Hg, it is known as a pulsus paradoxus on inspiration. So that is one important thing. You always get a typical finding in a cardiac tamponade. So there is a Beck's triad in a tamponade, which is the JVP is raised and you get a muffling of the heart sound. So that is one of the triad. Now constrictive pericarditis, I already told, again one of the causes of a prominent or a raised JVP. The A wave is normal, X descent is prominent, Y descent is prominent. You get a prominent Y descent, that is known as a Friedrich sign. Kussmaul's sign is positive in constrictive pericarditis, and A is equal to V wave. Now I already discussed, but there are conditions where A and V waves of a right atrium becomes equal. One of the first classical causes is atrial septal defect, because there is a communication between the right atrium and the left atrium. So right atrium A and V wave becomes equal because it is the left V wave which get reflected in the RA, and so A becomes equal to V. And also in the cases of CCP and restrictive cardiomyopathy, you get A equal to V. Just for remember, I discussed this. Now restrictive cardiomyopathy, also one of the conditions where JVP is raised, you get something known as A equal to V, and Kussmaul's sign is usually also positive. You get a prominent Y descent in restrictive cardiomyopathy like a constrictive pericarditis. The mechanism is almost similar. They are pericardial diseases. the X descent is also prominent, but Y is more prominent than the X in restrictive cardiomyopathy. Now, what happens in pulmonary hypertension typically is A wave. You should always remember JVP may be elevated. A wave is always prominent, but if you have atrial fibrillation, A wave is absent. If a PAH patient develops severe TR, you get a prominent V waves or CV waves and rapid Y descent. So this is the thing which is I don't want to tell again and again, but you should always know. In what happens in JVP, in ASD, normally, typically JVP is normal in ASD unless the patient with ASD develops pulmonary artery hypertension. So it is normal, but A equal to V in a normal case of ASD. When the patient develops pulmonary artery hypertension, you get a prominent A wave. When a patient develops PAH and then TR in ASD, you get a prominent V waves and Y descent. In patient with ASD who undergo Eisenmenger, the JVP may be normal, but sometimes you may get a prominent Y descent. What happens with ASD with MR, as I already discussed, V waves become prominent in JVP because the MR waves are reflected via the JVP in RA. So the V waves becomes prominent. And in patient with pulmonary stenosis, ASD with PRES is one of the causes of a prominent A wave. ASD with Lutembecker is one of the causes of prominent A wave in JVP. What happens in VSD? VSD doesn't usually much affect the JVP. However, you should know in Garbod's defect, you get a prominent V wave in JVP. But if a VSD patient develops severe PAH RV failure, you may get a prominent V waves. Epstein anomaly. You should also know that most of the congenital heart diseases do not affect the jugular venous pressure. Epstein anomaly is also one condition, though you should not confuse, though you may get a prominent Himalayan wave in ECG because RA is so hugely enlarged, you get a significant RA enlargement which is reflected in the Himalayan A wave. But because the Epstein's anomaly patient have an atrial septal defect, all the blood is decompressed into the LA and so the JVP is normal. So you should always remember this. Unless the patient develops later RV dysfunction, tricuspid regurgitation, where you may get a TR and a V waves. These are some important points. So in a patient with congenital heart disease, if you get a tricuspid atresia, it is one of the important causes of raised JVP, but in that case also they have a atrial septal defect which is usually restrictive. However, if the atrial septal defect is not restrictive, then again you may not get a prominent A wave, but tricuspid atresia is one of the important causes where A wave is prominent in congenital heart disease. So even in patient with TOF, you don't get a prominent A wave. So most of the congenital heart disease don't get a raised or a prominent JVP.